Flare Capital is a venture capital firm that's focused on investing in innovative healthcare technology companies. And we're very excited to welcome you to our 16th quarterly expert roundtable focused on building for scale in Medicaid. Excited to spend the next hour digging into Medicaid, the nation's largest health insurance program, covering 1 in 5 Americans. Despite the size of this population, it's important to recognize that Medicaid beneficiaries face barriers to care that have yet to be overcome. Housing instability, food insecurity, lack of transport, and other challenges that traditional healthcare was not built to address may create barriers to seeking care, making the intersection of health and social interventions critical. Even if a member seeks out care, access is a challenge. Only 74% of providers accept patients with Medicaid. This is in part due to lower reimbursement rates, as well as payment delays and claims denials. For those who have received care, it's historically been challenging to develop trust and continue to engage with this demographic. In fact, 40% of Medicaid beneficiaries indicate that they've been treated by a provider that they don't trust, and many are overwhelmed by complex systems that feel designed to work against them. To date, digital health funding in Medicaid-focused startups is significantly lower than in non-Medicaid focused companies. From 2011 to 2022, only 7.7% of the $101 billion invested in digital health was raised to support companies engaged with Medicaid plans. And that was also concentrated in a handful of startups. Some contributors to this hesitancy may include regulatory intricacies due to the interplay of state and federal laws, the complex intersection of health and social care, and the reimbursement landscape. Regardless, this is still surprising, considering in 2022, total Medicaid spend was reported to be $824 billion. We're at a pivot point, and many are considering now to be Medicaid's digital health moment. We expect to see increased activity from both innovators and investors, influenced by a few factors. There's growing recognition that a subset of this population drives the majority of Medicaid spend. These are members with significant physical, behavioral, and social challenges, and Medicaid plans are actively seeking solutions to improve care coordination and care delivery. Managed care organizations, or MCOs, are mandated to allocate at least 85% of their premium revenue towards medical costs, as defined by the MLR, and agencies are looking to contract out inefficiencies, often including innovative programs from early-stage startups. Further, waiver programs are granting states flexibility to test new approaches to care delivery, providing an opportunity to offer digital-first solutions to Medicaid beneficiaries. We've included a snapshot of some of the players who are innovating in this space, courtesy of our friends at Rock Health. In the light blue box below, you'll also see some of the Flare portfolio companies that are hyper-focused on impacting outcomes for those within this demographic. This includes Kayaba Care, whose CEO Adeze will be joining us later in the session, and it also includes Ounce, Positive Development, among other companies. Looking forward, we see white space for innovative models addressing clinical and social drivers of health that can improve outcomes and generate cost savings. These may include startups that support existing Medicaid providers or startups that are acting as providers themselves, creative models combining tech with an on-the-ground presence built with the understanding that it's not possible to impact health outcomes without addressing social determinants, population health data models to identify drivers of utilization and costs, providing insight into risk factors, and solutions that not only promote better engagement with enrollees, but also support Medicaid administrators with managing re-enrollment processes. Overall, we believe startups who prioritize policy acumen, population health data, and effective go-to-market strategies are best positioned to succeed here. With that, I am excited to be joined by a group of senior operating executives and entrepreneurs who will share their perspectives on innovation in Medicaid. We'll open with a fireside chat with Chris Palmieri, CEO of Commonwealth Care Alliance, to discuss macro trends influencing activity and policy implications. Then we'll shift into a panel of innovators to discuss building and scaling businesses for Medicaid with Adeze Anakwechi, CEO of Kayaba Care, Nikita Singareddy, co-founder and CEO for Tuna Health, and Dan Brillman, co-founder and CEO of Unite Us. And then we'll close with a fireside chat with Dr. Karen Amstutz, former EVP and CMO of AmeriHealth Caritas, on how startups can most effectively partner with payer organizations. So with that, I will invite my partner, Michael Greeley, to the stage for a conversation with Chris. Michael, over to you.
Uma, great setup for this important conversation. I'm delighted to be joined by my good friend, Chris Palmieri, who's had a very long and distinguished career in this sector. Chris, I'll let you introduce yourself in just a moment, but you've spent almost a full decade now running CCA. Please, you should describe the scope of your services, but you also sit on a number of boards in our sector. And so I think you have a terrific perspective on innovation in the category. But Chris, let me give you a minute or two to introduce yourself and what your CCA mission is.
Yeah, thanks, Michael. I'm glad to be here. It feels like we just met yesterday, although it was now 9 years ago. So today, CCA, also known as Commonwealth Care Alliance, is about a $2.8 billion organization. We're headquartered here in Massachusetts. We are a nonprofit. We provide insurance coverage, care delivery, ACO services to about 120,000 people. We have a presence in multiple states. Massachusetts is our primary market. We also own Medicare Advantage plans currently in Rhode Island, Michigan, and California. Our focus has been on serving individuals either through insurance or care delivery that have complex healthcare conditions that we think benefit from interdisciplinary coordinated care. And in all of our markets, we've tried to create tailored care plans through a robust network of healthcare providers, not just folks we employ, that's actually quite minimal, but really through a network model. And we're looking to move the site of service away from hospitals, trying to reduce hospitalizations and ensure the quality of care for our members. Here in our primary market in Massachusetts, where both you and I spend a lot of time, we're focused on two products called SCO and OneCare, and those really exemplify personal care coordination and do provide, through the reimbursement mechanism, holistic patient-centered services, as well as care in the home, behavioral health supports, prescription drugs, and long-term services and supports. We've been focused on providing care for underserved populations, and I know some folks later are going to talk about social determinants of health. I think we're all striving for, but we've been really focused on now the quintuple aim, which is to have patient-centered care, to manage population health, which is addressing social determinants and wellness in communities, clinical satisfaction. So those that are actually doing the work as our employees or subcontractors are actually enjoying the work and able to do it without significant burnout. And then, of course, reducing quality and accessing health and advancing health equity.
Yeah. I wanted to hit some of your key strategic priorities as you think about planning for 2025. But given some of the overview data that Uma just presented, how are you reacting to that? The level of innovation, funding, it's acute, obvious, pressing, and yet investors are struggling with how to invest in the sector. Just how are you thinking about that?
Yeah, I'd say the companies out there that offer Medicaid managed care or any type of sort of footprint in Medicaid really need help. Traditionally, Medicaid has not been a segment that the rates have created profit pools. And so the dollars are really short. And I think there's a huge opportunity for innovation to address all these things that I just said. It's even for a company like ours that when I met you, we were a struggling company that was subscale, and now we're at scale, and it's still very difficult to do everything we want to do on our own. So we've looked to partners to do this. And I think it's been more of the agile venture capital backed organizations that can move really quickly, get product out to market, understand our needs as well as those of the end user consumers, and be able to do it at a price point where we can create a tremendous amount of value. For us, it's by saving money and hopefully meeting our narrow margin target, and then allowing these companies to have revenue that not only meets their costs, but they can make their profit targets as well.
Yeah, no, the turnaround you've effected has been impressive, reported upon. So congratulations to you for that. As you think about near-term priorities, what does the next 12 to 36 months look like? Where are you going to be deploying resources? Just talk about some of the near-term initiatives.
Yeah, first of all, we, like many organizations, changed our operating model because of the pandemic. And our primary focus for 2025 is to get all of our clinical workforce back out in the field, in the homes of our consumers in Massachusetts. So that will require us to do about 100,000 in-home visits for 45,000 people. And that's a big change for us because our workforces have evolved. People have moved away from the service area. They've gotten comfortable with working remotely. Our consumers, we believe, need services back in person. And it's not just from what we'll provide directly, but also what our partners will provide, our subcontractors. So there's a big push for that. The other thing that we're looking to do is we want to, maybe on a smaller basis than Flair does, but potentially as a partner, we want to continue to deploy capital. Through Winter Street Ventures, we've made 15 investments now since I created it in 2016, and we want to bring in some outside capital to continue to help create this ecosystem of entities that we believe can meet the needs that I've already described as quintuple aim better than we could do it ourselves.
No, it's been obviously hats off for being so creative on how you deploy capital from your balance sheet. What are some of the themes that are coming out of the portfolio? What are some of the learnings of your in-house venture portfolio?
Other than it's incredibly hard, I think that we have not given up on things like primary care. We still believe for the populations that we serve that individuals suffering from multiple chronic illnesses, taking 8 to a dozen medications a month and still using the emergency department as their primary care office site, we haven't given up on primary care. And we're really excited about the continued evolution of what primary care can provide. And I think we need it more than ever. I think as well, this whole sort of focus on social determinants of health is something that either as an investor or a consumer, we think that things like housing security, transportation, food security really can help people live a better life and hopefully, again, keep them out of the hospital. And then behavioral health support, both through connecting consumers with care coordination, understanding someone's behavioral health issues and mental health issues, and getting some access to at least awareness. And then awareness is the first step, and then ultimately to treatment. Those are some of the areas that we've focused on, both as an investor as well as a place that we want to deploy capital. And I still think there's a long runway there.
Yeah, and we'll hear from some great entrepreneurs shortly, particularly what Dan's doing around Unite Us and the SDOH category. There's a false equivalent, so we basket all of those issues in one basket. Where are you seeing the biggest impact on your members around food security or housing? How do you stack rank the urgency of those needs?
I think housing's the most urgent. We've done a lot of work for our members as well as for dealing with the migrant population that's come here to Massachusetts from other places. And we're caring for nearly 10,000 people now in that, which is outside of our insured businesses, but fee-for-service model. So housing, I think people need stable housing, whether they have any type of healthcare issues or they're suffering from drug addiction or mental illness or chronic illness. Stable housing is number one, and it's been really challenging to direct Medicaid dollars or federal dollars, for that matter, into getting someone stable housing, but it's a huge priority for us. Transportation continues to be, it sounds so simple, yet it's so complicated to get people reliable transportation so they can get where they need to be, whether it's their medical appointments or socialization. And then food security. Again, making sure people have food to eat, but not only food for us, it's tailoring the nutrition to what their care plan is and making sure that they understand and can access the food is really incredible. And none of those things are actually medical issues.
Yeah.
Again, the medical issues often take a back seat to these things, but these are areas that we think are just really critical for folks to be able to live a more robust life than they are today. And I would say these are things that they literally need to stay alive.
Yeah. And are you seeing productive, successful, innovative new models to address some of those issues? Can you cite one or two examples of vendor relations that you're seeing impact?
I think we're making progress. We've tried a lot of things with transportation, for example, and we took some bets on some early companies in transportation. I think we're making progress, but that still continues to be a mosaic of a variety of different options, given that some folks don't need assistance, others need significant assistance to get in a vehicle. But that's an area that I think is still ripe for not only aggregation, but also just doing it better to tailor what the needs are. We do a significant amount of transportation, somewhere between $30 and $50 million a year we spend on transportation, which is significant when you're thinking about the medical budget that we have to live within. And again, it's not even a medical service. I think that the food security is moving in the right direction, meaning that the type of food that's being made available to consumers through third-party payers like ours, first of all, the food is better than it ever has been. Secondly, it can be tailored to someone's diagnoses. And third, it's at a price point that we can actually afford within the Medicaid construct, which is a much, unfortunately, lower threshold. I'd love to see more dollars available, but we do believe that we're making great strides here. I would say on other mental health areas, and Marigold's a great example that we've been working with. I think we're making a lot of progress in terms of, again, bringing some of this technology into an operating environment like CCA's where we employ 900 caregivers ourselves. And
Chris, let me
but we
press
can't
you.
do it all. Yeah.
Let me press you when you say progress. What are the specific metrics that you're looking at in the near
Well,
term?
we're looking at, first of all, will a consumer engage?
Yeah.
That is number one. Can you get a consumer to engage in these services, or is it just another name that's on a roster? So engagement is one of our first measurements. The second one is consumer self-reported loneliness and isolation. And then you obviously can get to the bigger metrics, which is, again, is somebody dialing 911 because they're having an escalating issue, whether it's loneliness or fear or something.
Yeah.
Those are there's these micro measures, and someone could step back and say, I don't want to use government resources, Medicaid dollars, just so someone has a perception that they feel better. But actually that matters, because if they have their own self-perception that's positive, they will actually engage in other areas of healthcare that brings down the total cost of care.
Yeah. So I hesitate to wade into the whole AI discussion. So I'm going to frame it differently. In 10 years from now, if you're still running CCA, how will the organization have changed? And then parenthetically, does AI play a role in that new care model?
AI has to play a role in the care model. And there's been a tremendous amount of regulatory concern and debate around whether AI should be ultimately making the decisions. I'm not suggesting that. And I continue to believe that human touch and human interaction is going to be really critical. But I think about, if I have to spend dollars to get a human into someone's home, there's a tremendous amount of overhead on that. So I could actually have that individual prepared, our employee or someone that even is in a partner company. They can be prepared with all of the information that exists in the healthcare ecosystem, and then have predictive analytics to really help us understand where, based on all the factors, that consumer could be moving to and what we can do to get upstream to prevent that. I actually don't think that's 10 years away. I think that's probably a couple of years away. And again,
you'll see efficiencies in workflow, clearly, but do you see AI replacing some of that labor and the point of care? What does that interaction
make
look
the
like?
labor more efficient? As we continue to scale up, one of our biggest pain points or choke points has been getting the right people to do the work and making it a role that someone is not completely pinned underneath. Because with manual processes, you're left to your own memory and multiple computer programs and screens and Wi-Fi connectivity, et cetera. I want to make sure that if we can have a human interaction, that it can be manageable, and meaning that a lot of the decision-making has been brought along to a point where the clinician or whoever's having that face-to-face encounter has a tremendous amount of confidence that they're going to make the right decision, they're going to deliver the right information. And I think with using the technology that you're describing, that will make our folks much more effective through efficiency. So meaning that they're not worried about if the conversation in the home, because they can't get the information or it takes a different turn, lasts 10 minutes more than it was supposed to, is that going to in any way negatively impact the next visit they need to make, or the visit they need to make tonight at 5 o'clock?
Yeah. All right. Last question. In the last minute that I have you, obviously it's an election year. Without making political commentary, how are you bracing yourself for either outcome? And we may not know that until next year, but how are you positioning yourself? How's Medicaid positioning itself for the outcome?
We focus on a population that is called dual eligibles, which is folks that have Medicare and Medicaid. And we woke up as a society almost overnight with 51% of Americans in Medicare Advantage. And for whatever reason, while I think that's an incredible success of the advancement of value-based purchasing initiatives, there are people on both sides of the aisle that are concerned about that. And the way that you bring down that level of penetration is you change reimbursement, coding intensity, you add additional regulations. And I think what we're going to see is an exodus of people, now 1 in 2 in this country, 39 million people are in Medicare Advantage. You're going to see an exodus back to fee for service. And I also think you're going to see a shortfall in funding on any program that coordinates payment with Medicare and Medicaid. So we are bracing for some very significant headwinds, potentially ultimately reimbursement and funding shortfalls on the Medicaid side, even here in Massachusetts, which has been very pro Medicaid expansion and helping people get the care that they need, even if they're dual eligible. So I think there's going to be some financial headwinds. And I certainly think there will be a period, irrespective of who's elected, because it's going to be a new president irregardless, that there's going to be just a period of things, we're going to be in a transition. And we're
Yep.
going to be in a transition at a time where utilization has risen significantly. Reimbursement has already come down. So doing nothing is not going to be helpful as well.
Thank you for your time. CCA is fortunate to have your leadership. It's going to be a tricky couple of years. I feel very good about the prospects of CCA. I'm going to turn the mic back over to Uma to have a conversation with some great entrepreneurs who are hopefully going to sell product to you, Chris.
It sounds great. And it's, again, I think with challenge breeds opportunity. So I remain optimistic, Michael. Thank you for the time.
Great way to end. Uma, over to you. Thanks, Chris.
Thank you.
Great discussion. Thank you, Chris. Thank you, Michael. We have three very talented CEOs who are joining me on the stage right now, Dan, Adeze, and Nikita. To kick things off with the intent of providing folks who might be less familiar with the organizations that you each are leading with context for the discussion, I'd love to go around and have you each share 1 or 2 sentences on the companies that you're building. So if we can start with Dan and then Adeze and Nikita, I think that'll give great context for the discussion.
Well, great. Thanks for having me. I think Chris and Michael already answered what is needed and what we do, but I'll start with Unitas is the leading national technology infrastructure that connects healthcare, government, and social services together to do a couple things. One is predict needs, deliver those services through these community-based organizations, and then being able to pay for those community-based care. Over 11 years, we brought together with boots on the ground, focus on the community, about 1.5 million community-based services, along with 1,200 payer, provider, and government customers to communicate in real time and coordinate in real time, predict those social needs proactively with their constituents, and now enable billing for billions of dollars now to be reimbursed for those services as a technology infrastructure.
Thank you, Uma. I'm the CEO of Kayaba Care. We deliver complete wraparound services to expectant and postpartum women. We're primarily in the Philadelphia, South Jersey MSA, but should be expanding relatively soon, very soon. And in doing that, what we focus on is really addressing the empathic, holistic services that pregnant moms and postpartum women often lack when they interact with the medical system. We address social determinants of health, as you just heard mentioned in the previous, the prior section. But what I often say to our teams and some of the investors and payers we speak to is operationalizing empathy. What people need is not just solve my transportation problem. It's how do you speak to them? How do you answer their questions? Do they feel safe when they interact with the medical system? And that's what that's very hard to do. All of this is very hard, but that's what we really focus on as part of the entire package of what we offer. Again, some of the outcomes we look at, we can certainly talk about that. How do we reduce some of the unnecessary expenditures with respect to maternity care? How do we reduce NICU visits and make sure that the moms are thriving, especially in that postpartum period?
Awesome. I love that Adeze and Dan already started teeing up, getting into outcomes and getting into data. I love that that's already an orientation on this call. But I'm Nikita. I'm one of the co-founders of Fortuna Health. We like to brand ourselves as TurboTax for Medicaid. So I think what that means in a very simple way is navigating a consumer, their family, household through understanding Medicaid end-to-end from eligibility, enrollment, and recertification.
Great. Thank you for those introductions. I'm really excited to jump into the discussion. All three of these companies have really excelled in serving the Medicaid demographic, but each are tackling very distinct areas within. So I wanted to just start off by discussing the concept of trust, because a lack of trust in the healthcare system is what represents a major barrier to Medicaid beneficiaries accessing care. So beginning with you, Adeze, people with the highest risk of maternal health complications oftentimes have the least access to care. So how does Kayaba Care cultivate trust and empathy to promote engagement?
Thanks for that question. So we do that a number of ways. It's baked into the model itself. So when we engage with our members, we're not dropping in and dropping out. It's over several months, a year actually, of consistent touch points. We meet our members where they are. We meet them in the home. We see them at coffee shops. Some people don't want you to come to their homes right away. So we'll meet them wherever they want to be met. And we also, of course, meet them virtually. That in and of itself cultivates trust. You're not dictating to them, how this relationship has to be established. The fact that we do it over a consistent period of time, I think it just takes into account what is inherent in human beings, which is that if I see you once, I have no reason to trust you. If I see you and talk with you over a sustained period of time, that's how you build relationships. And that's part of the model. The other most important aspect of cultivating trust is that we hire our navigators. The anchor relationship with our model is the navigator. Our navigators are hired from within the community. People who understand you, speak your language, understand some of the dynamics, if you will, or the nuances of your community, make a big difference in cultivating trust and talking to someone or engaging with someone who doesn't make you feel judged, doesn't make you feel ignored, certainly will not ignore you or gaslight you. The newest term, I think, in the last 2 years, which is quite real and a real threat to engaging with members or patients in the medical establishment. And of course, it facilitates or can break down their adherence or compliance with whatever medical protocols our OBs would want to see. So we are wrapping around the OB, and we're resourced to do essentially everything they are not resourced to do.
That's great, Adeze. And follow-up is for Nikita, because there's been a lot of discussion around tech receptivity and access for Medicaid beneficiaries. So how has that influenced how you've built Fortuna's tech stack?
Yeah, great question. I think in general, there's a ton of misconceptions around Medicaid beneficiaries. And I think all of us on this call can speak to that, whether you work from the care delivery side or from the services and CBO side. 90% of folks on Medicaid have a smartphone, either them or somebody else in the household. So I think generally we need to grow up, frankly, from this paternalistic mindset. Everyone and their mom has a Facebook. However, I think it's really important that you earn trust by having a great consumer experience by just frankly doing the thing that you say you're going to do. Because this is a population as well that has been consistently oversold, said that you're going to get X, but actually delivered on Y. And I actually think, given Michael talked about AI earlier, and so did Chris, we, for example, don't lean into AI. We don't talk about it. It's not a framing at all. We spent a ton of time in the field doing research when we built the product. And frankly, beneficiaries don't care about that. They want something expedient and they want something that works as advertised, just like everybody else on this call. Language, though, and competency does play a huge role. So I want to shout out Adeze for mentioning that. Chris also mentioned the migrant population. And I think what that means, to go a level deeper, is, of course, understanding the community. And at a high level, it means understanding the difference between somebody who speaks Mandarin. The concept of Medicaid doesn't mean anything, but the term white card does. That translates given some of the contextual context in mainland China. Lastly, to build on trust, that is also related to technology, is we partner very closely with our hospital and managed care partners. Their names are very important for building that brand, for building that trust and conversion with our consumers when we're still a startup today. So we're still earning that trust. So beyond our technology speaking for itself, our partners also play a big role in that.
Lots of great comments that are packed in there. Dan, I'm curious, with Unite Us, I imagine that as you were scaling to different markets, it was important to have local teams who really understood the needs and the available resources in each of those communities. So in markets where you felt that vision was executed on very well, what was secret to the success there?
Yeah, it's a great question. And I think to the other points, it all starts with community, and it's been our differentiator since the beginning of 11 years. And so going back to where almost my intro, right? Like what we are proving to communities over 11 years is how can you have visibility on what happens to your client after they leave the four walls, right? That's housing, employment, benefits, behavioral health. That takes a new type of trust that has just never happened before Unite Us. And then as our products evolved, how do you move from reactive and crisis to proactive? That needs analytics, all of us on the same page as a community, who's doing what at what given time, who's on first, who's reaching out, who's asking the right questions so the patient's not being asked 100 times different things and filling out paperwork, right? And then it was, all right, how do we actually invest in these organizations, build capacity into these core services to ensure people live healthier lives for the first time? And it's been all part of our core differentiator is building locally with technology, with people on the ground, with communities, which is important. And really it's two things. One is we had to build standardization, a standard in an ecosystem that didn't exist, not from a healthcare lens, but from a community lens that's building with the community. And we'll talk about it a little bit more. And then second thing is always evolving faster than the market, skating to where the puck is going, only because this has not been built before. And so we always have to stay a couple of years ahead of the market. And so building this with communities, 11 years ago, we had to agree on what was going to be shared electronically for the first time, what's going to come back across 150 types of services. Over 11 years, that's become a standard. And so then we had to meet the needs of the community and show them efficiency, how we're replacing all the manual inefficient work they were doing. Even on the recipient side, people would just show up to organizations, say, how'd you get here? Oh, I got a piece of paper. And sorry, I can't take you. So we had to make that electronic. And what's most critical for that is the voice of the customer in the community. And we've evolved so much, even as a technology company, all of our features come from the community, whether it's real-time chat from the EHR to a homeless shelter, because they were maybe still picking up the phone, to Unite Us Payments, which started 6 years ago, which is how do you actually reimburse those services, which is now billions of dollars accessible through Unite Us in the community. And so it's all about being on the ground, knowing what's happening, both the experience of the community and the people that are being served, and then how do you make that live in technology?
I love the historical context there over the last decade or so. Shifting gears a little bit, what is it like building a business that is primarily serving Medicaid? It's exciting to hear that Medicaid plans are actively seeking out better solutions for their members, but then there's also discussion around the ability to scale given the state by state go to market and the complex regulatory landscape. So just take a step back, and what would you reflect on as the biggest challenges and the biggest opportunities here? And do you feel like we're at an inflection point? And I'd love to begin with Nikita and then Dan and then Adeze.
Yeah, Chris said it well when he said that the things that other people fear, the complexity, the challenges are, if you love, that can be your competitive advantage. And I think everybody on this call are people that love to lean into that because other people are frankly terrified of that. And there are reasons to be. There are slimmer margins in this space. You do have to make things work extra hard. But I think that then becomes incumbent on you and your business to make sure that you are identifying what's scalable versus, to Adese's point earlier, and Dan's as well in community, what requires the human touch. So will you need navigators for some specific part of that, but what can be digitized and digital? So I think reflecting on that, we've made certain decisions as a business around, for example, we didn't start in the dual space because frankly, for navigating LTSS, navigating waivers, that's a lot harder for us as a business to build scalably first. So picking the wedge and deciding for us, Magi Medicaid was where we were going to lean in. That was very helpful. I think the second thing is not trying to do everything all at once. You can't be a one-stop shop when you start a company. So you pick what are the things, again, that we can build really well and that we do think can set up to scale. And I think Unite Us is honestly an awesome example of seeing how that has played out to be a billion-dollar business. So thank you, Dan, for leading the way where other founders are looking at what Unite Us has built. And then I think the third is there is a lot of information out there as well on Medicaid. I think there is an idea that there isn't. It's there, but you have to go find it and you have to go hunt for it. So again, if you want to lean into that as a competitive advantage, the information is there, the people and the knowledge is there. You just have to bake it into your culture and your business.
I'll jump in here. So I'm super excited. And so just as Nikita said, by the way, we've been around for 11 years. There are always going to be headwinds. There's always going to be massive problems to solve. They're just going to change. And this obviously goes out to the founders and that are on the phone here too. Like our vision and mission for 11 years has stayed the same and it hasn't changed. How we've gotten there and navigated through that, of course, will continue to change and do that. But going back to this core of what Unite Us has done, and we haven't solved it all, but like everyone knows this is a problem. You just heard from Chris, right? It needed to be solved. Just how were we solving it? Nobody was solving it together from a technology perspective. 11 years ago, everyone was doing this for the first time on Unite Us electronically, actually closing the loop. We had to show improved administrative efficiency, removing the majority of offline and inefficient processes. That was like first step. 2019 was, oh my gosh, we're going to do this like statewide in 16 states simultaneously as a company. And in the community, there were massive early adopters and then over time, the network effect happened. Oh, this is like everyday process. This is the way I should be doing this. And because I can get better, I have better data on what's happening with my clients outside my four walls, I can get more funding. 2021 was the first social care claim ever sent through our country, through Unitas. And so not that long ago, a CBO was paid through a medical claim through a technology system. And obviously we think of this as no-brainer stuff as founders on here, right? But North Carolina, massive ROI, $85 PMPM savings, reduction in ED visits, right? Lower risk, like this stuff works. The questions that obviously came from Chris and the group is like, what's next? How do we actually continue to push the market? And there are really positive signs of that, right? Especially in Medicaid with MCOs adapting this work, especially as they go out to bid, Joint Commission and CMS, obviously helping screen for social needs. And obviously we don't just want to ask the questions, we want to address the needs. So it requires new type of connectivity. And so it's around bringing everyone along in that evolution. And what we always say is these problems are going to continue and be hard, but we're going to solve them together as a community. And that's what's most exciting about what we do.
Yeah, no, it's a great question, right? So let me offer, because I agree with everything that's just been said, let me offer some additional thoughts. From the payer's perspective, they have a pretty difficult challenge in front of them, which is the death by 1,000, maybe 3,000 point solutions. And some unfortunate person is responsible for sifting through each of those point solutions to figure out what's real and what's not. And that is a hard job. So in the cottage industry of maternal health, perhaps you're looking at 10, 15, and some are hollow. Some are not going to ever achieve the outcomes that health plan desperately needs on behalf of its members. And so my job as a CEO of one that is the antithesis of hollow is to prove it, is to prove that we work, to prove that this is a substantial model and that the inputs are necessary to drive those outcomes. And we have a paper, anyone who knows me will not be surprised by this. We have a paper under review because we believe that the data are more than compelling to show that this is a model that works. Hopefully it's published and you'll see me post it on LinkedIn. The other part of my job, though, is to ensure that as we are doing this work and talking to health plans, that we're showing how this is a meaningful and engaging model that is actually scalable. And in doing that, I have to distill this work and our model to the most essential inputs. What is really necessary? Because this has to be affordable for the Medicaid plans that we're selling to. They get a certain amount from the states. This is a federalism experiment that is ongoing since 1965, right? The federal government contributes and states contribute. So there's not unlimited dollars, and there never will be. So we have to make this offering affordable and demonstrate to our payer partners and to states that are looking still to address maternal health, because it's actually been getting worse for Black and brown women, that this is the model to invest in, this is the thing to do, and it will never be a waste of time. We know from one of our Medicaid plans, we save them about 30% relative to a comparable group. And we do that because the babies are not ending up in a NICU. The moms are not going to the ED unnecessarily. They're not using hospital services unnecessarily. Preterm deliveries, low birth weight, all of those things come down drastically. But that's what the sustained engagement, human-driven, tech-enabled offering does. That's what it achieves. So we have to then distinguish ourselves from something more hollow. I wouldn't name anybody. You know that light touch that doesn't drive anything. You know it when you see it. And we have to then, of course, make it affordable for our payer partners as well.
I have so many follow-up questions for all three of you, but we are at time. But Nikita, Adeze, and Dan, thank you so much for hopping on. Congratulations on all of the progress. We're looking forward to continuing to follow what you're building. And now I'm going to invite my colleague Dan to the stage for the next chat with Dr. Karen Amstutz. Thank you all again.
Thank you, Uma, and thank you to the panelists. Such a great conversation. I found myself nodding my head and laughing at some of those truths that were told. So that was really great. And Karen, it's really great to have you. I really appreciate you joining us today. It's been a great pleasure. to get to know you over the last several years as you're on the board of our company, Vita Health. But for those that may be less familiar with your background, Karen, talk us through a little bit about your career trajectory and some of the populations that you've had the opportunity to care for and help manage.
Awesome. Thanks, Dan. And it's such a privilege and honor to be on the stage with all of you and be a part of the conversation in this group. I think, as you realize, I'm a physician by training, and early on decided that the intersection of business and medicine was going to be a fascinating place to be. And as such, I've spent 30 years in managed care across all products, but really with a concentration on Medicaid and Medicare Advantage. Most recently as EVP and Chief Medical Officer at AmeriHealth Caritas, a large national Medicaid health plan. I've led organizations and been in roles that have designed that clinical model, figured out the deployment of it, and then also, as Daisy, I think, was saying, had to sort through the solutions as well as figure out how we are going to adapt and customize our different solutions to the challenges, the unique challenges in each of our Medicaid states and Medicaid plans.
Yeah.
That's really where I've spent the majority of my career, is really thinking about these underserved populations and what the programs look like and how do we deploy clinical models. And it is this combination of both scale and in-person that makes the sort of deployment of them so challenging.
Yeah, no, you called it out, and Adeze kind of gave us that perfect transition. By definition, populations served by Medicaid have the most needs. There are so many problems to be solved, but ultimately the managed Medicaid plans themselves, our businesses, have a certain way of doing business and have to reach their strategic goals. So hopefully in this conversation, we can maybe strategize how do early stage companies best align with some of these strategic goals. And we probably have over 500 people tuning into this conversation, probably over half are entrepreneurs or operators trying to help solve some of these problems. And so hopefully we can not just be thematic, although we should talk about some of the issues that are being solved, but also talk about tactics. And so in your experience, kind of Karen, working with some of these early stage companies, what common mistakes or smart strategies do you see early stage companies make when trying to engage with Medicaid and managed care plans as customers?
I think what makes it tough are a couple of things. One is I'm trying to identify that problem that you're solving, and you may be solving it with providers, with members, and at the same time, you actually have to deeply know the managed care company and their unique requirements as well as a customer. So it's almost like you've got these two pillars that you have to be very competent at. In general, if giving advice, it's really know what your problem is, which I think goes without saying. Think about how you're going to integrate into the ecosystem of both the provider community, potentially the social determinants of health communities, as well as how are you going to take your solution and make it really easy to deploy for the managed care company. I think, although most of us would say we hate the word pilot, being able to spin something up fast and quickly prove that it's going to be effective in your own environment is a real plus. And then as well have solved for how do you make that then easy to adapt it, particularly for a national company, and then begin to roll out across the multiple health plans. It's important to understand the business model too and the funding streams that you have to work with. In general, right, managed care companies are working on 85 to 87 cents on the dollar of the revenue dollar sitting in that MLR, the medical loss ratio, and the other, hopefully you're getting to 8 or 9 cents spent on admin. And of these two modalities, it's probably faster to be able to contract as a provider. There's also obviously more dollars and a bigger revenue stream there. And my advice would be if you have a product that can come in as a provider and bill using the fee schedule, that's really helpful. Being able to take advantage of other revenue streams is also helpful. So there are other federal funded revenue. Let's say you wanted to solve food insecurity and you understand, hey, in most states, 20% of people who can get SNAP dollars aren't getting them. And I have a solution that can really, beef that up. That doesn't beef that up. That doesn't cost the managed care plan anything because for the food dollars are coming through another federal funding stream. So really being able to take advantage and have a business model that potentially has what we would call a braided funding stream is another piece. And then finally, the more I think we talked early on about the quintuple aim, the more you should be solving for at least 2, if not 3 of those 5 parts in a solution. And again, with proof points in a Medicaid population.
No, a lot of great insights there. I heard not only understand your problem, but understand who you're solving the problem for. and how you integrate with their existing ecosystem. I heard that the power of actually demonstrating results via a small kind of controlled population and then in a pilot, and then potentially landing and expanding that revenue model, ultimately understanding that health plans and managed care plans have very limited admin budgets. And if you orient yourself as a care management vendor, you're further decreasing the pie associated with admin spend. And so actually being a provider, you now tap into the medical expense budget, which is significantly larger than the admin budget, is quite powerful.
Absolutely.
So that's really great insights. And maybe you talk a little bit about the quintuple aim and the types of problems that are being solved. I'm curious, when you think about the value propositions that early stage companies have when they're delivering solutions to managed care plans, which value, because not all value propositions are created equal, and depending on which plan at which time you're talking to, they may be valued differently. So I'm curious, when you think about value propositions, which value propositions resonate most strongly with managed care plans? There are opportunities to quote unquote reduce cost savings on the medical side, maybe growing top line and membership growth, quality bonuses, regulatory compliance, competitiveness, right? When you think about state bids and RFPs. So I'm curious, which value propositions resonate perhaps most strongly with Medicaid plans?
So I think that's a tough question. I would say all of the things that you mentioned are really important and are constantly getting attention in terms of making sure that you've got successful strategies. A couple of things that I would definitely think about. I think we're seeing more small stage companies segment the member population very successfully and have solutions that target that specific segment in a way that impacts cost in some way. There has to be a business model in this, that goes without saying. But secondly, also is demonstrating some other outcome that's really important, whether it's engagement, whether it's clinical, whether it's trust, whether it's a clinical outcome. And financial also goes without saying that the revenue side fits into that, improving revenue, improving retention of members. All of those are really important, but you do want both the financial and some other outcome that is really important. The more that it's unique, the more unique that outcome can be, or the more broadly that you can create an outcome within a population, the better, because I think folks have alluded to building trust and getting member engagement up is such a core priority, both for managed care companies, and increasingly states are associating that with performance guarantees as well.
No, it's insightful. I heard a couple of themes there. The ability to segment the Medicaid population, which I think is powerful, because oftentimes people think of Medicaid as this kind of monolithic entity. Everyone on Medicaid all looks the same. But as you described, there are very defined segments, right? There's older adults, right, who may have disabilities or be low income. There's mothers and babies. And so understanding that each of these populations are going to have different need sets, and solutions need to be built for purpose, and the business model needs to align with that. And then the other thing that I heard you mention, which is powerful, is it can't just be about cost. It can't just be about the dollars. There also has to be clinical impact or some form of engagement and retention impact. So again, really thoughtful. I'm curious, maybe more on the tactics side, just decision making. How are buying decisions made in a health plan? As you can appreciate, these organizations, at least from the early stage company perspective, can seem quite opaque. You make a presentation, you send across the desk, you don't hear anything for 6 weeks, and you really don't know where you stand. So maybe kind of open the kimono a little bit. How are decisions made within these managed care plans?
I think what you're going to find is there's a big joint collaborative decision making that always is going to include the health plan leadership or market leadership, the chief medical officer, and the chief financial officer. And all three have to be convinced that this is going to be a good next step. What I would say is that each managed care company, though, has a different approach to how it vets, particularly on the vendor side, or for that matter, how they contract with providers. So you have to really take each organization and say, is this an organization that's looking at things nationally first? And then if they've endorsed something nationally, then your local plans then can figure out how they're going to adapt it. Is it something that's done nationally and then pushed out? Is it something that actually is unique? And there are going to be organizations that allow the local plans to the opposite. Let's let the local plan pilot this. And if it's really successful, then we'll think about how we go nationally. It is important to both understand how that's going to work in an organization, but also keep in mind how you're thinking about your contracting process as you're going through this, to actually allow to ensure that as an early stage company, you have initial contract that's going to allow you to go big if you have the opportunity. I would also add that it's extraordinarily important in these companies, the security, the IT security. There may be a very high IT security bar. So as you're thinking about designing the product, you have to actually put a big emphasis on being able to actually understand, know what those requirements are, meet them, have the certifications in place before you go, because that's a deal breaker. If you don't have particularly the information, the IT security in place, you won't be able to successfully contract.
Yeah, no, it is quite revealing that there is so much work that has to happen in the background, as you're describing, across departments and this kind of collaborative decision making in order to get to a yes. If an early stage company doesn't hear from the plan for 6 weeks, to use the Daisy strategy, they're not gaslighting you. There's actually a lot of busy work that's happening. And the other thing I heard you mention, which again is quite powerful, is sometimes a decision to contract is not made in isolation. You're thinking about how does this scale within the organization, whether it's with one state regional plan or with its expanding nationally across several regions. And so how can you bake that into the contract itself? How can this kind of be set up to be taken to broader scale? One of the things that you touched on earlier, which again, I think is a pet debate, and Daisy also mentioned it, this concept of death by point solution. And then you'd given the advice to go broad. I'm curious, it's a big debate, point solution by versus platform. How do plans think about it? And again, I would just share my perspective. Sometimes we give point solutions a really hard time, but if the problem, that single problem is big enough, you will see plans work to contract with these entities. So I'm curious, point solution versus platform, the decision to go broad, how do you guys think about that?
I think you've outlined the two options. One is a point solution that is just a really big problem and can go very deep, and it solves a critical need that is going to be very, very difficult for the plan to solve, or it's just faster to be able to incorporate a point solution. When I was talking about going broad, it's really about having a solution that can actually be deployed in multiple health plans and not just unique to a single market. And I think as new companies are thinking about this, you really have to have that set of variables across Medicaid that are the ones that are the key success factors for you in any given Medicaid market, so that you can go in and evaluate those. And I'll use the example of someone who's coming in with an innovative provider solution. You've got to know whether or not, what price point you need in order to contract with that, and what it's going to take for you to be successful. And there may be Medicaid markets where the fee schedule simply is such that your solution is not going to be viable either for you in a fee for service, or even for the managed care company, because their rates are based on the Medicaid fee schedule in any given market, and that varies drastically. You could find in one market that a fee schedule is half what it is in another market, and therefore your product really won't be viable. So really understanding those key variables, analyzing them, and making sure that, again, as you're thinking about the managed care companies, that you're clear what markets you think you're most likely to be successful in.
And related to that, Karen, so much of what you described is understanding the plan's business model, right? And how it impacts their purchase decision. In your experience, do you see early stage companies like asking for this information? How can they learn about this as they're entering into a purchase decision or a contracting process? How can they better understand the plan's kind of constrictions and limitations?
I think I've seen it happen all ways. I think, unfortunately, a lot of times it just happens by trial and error, right? You have a new product that's really successful in a certain state, and then as you try to go to another state, you realize, oh my gosh, these variables that I need to be successful just aren't there. So I think this may be also an area that Blair, and I've seen this with other capital partnerships, can also have some of the expertise and maybe even track and have analyzed some of these key Medicaid markets. So the things about just crucial membership volume, crucial provider concentration issues, fee schedule, a whole number of other variables that may impact, and then allow you to guide a successful market entry path for the companies that you're funding. And I've seen that be helpful. Otherwise, I think that companies are finding consultants who can give them this information, because I think, as Nikita pointed out, sometimes it's really buried, and you have to know what it is you're looking for in order to find it.
That's fabulous, Karen. Really insightful. And I know our audience members really appreciate it. We could talk for another 20 minutes, but unfortunately we're out of time. Thank you again, Karen. Really appreciate your time and look forward to catching up again soon. With that, I will
Dan.
turn it over to Uma.
Great. Thank you, Dan. Thank you, Karen. Let me conclude the session by thanking each of our speakers for their time and their insightful perspectives. We did cover a lot of ground. There's a lot more to talk about. So as always, please do reach out if you're interested in continuing the conversation. Thank you.